Gonioscopy-assisted transluminal trabeculotomy, a boon for challenging case scenarios. Glaucoma is the leading cause of irreversible blindness, and trabeculectomy is considered to be the gold standard surgical treatment. However, it is associated with vision-threatening complications. The rise in glaucoma patients has stimulated novice surgeons to opt for safer surgical options. There is a therapeutic gap between lasers and pharmacotherapy and glaucoma filtering and drainage devices filled by newer MIGS procedures. This array of minimally invasive glaucoma procedures has added more safer options to our armamentarium, out of which GATT is one of the most efficient and economic option. These procedures are minimally traumatic, safe, with moderate intraocular pressure lowering and provides fast recovery. As described by Grover et al., Gonioscopy-assisted transluminal trabeculotomy is a procedure in which trabecular meshwork is bypassed via a microcatheter or a suture 360 degrees along the Schlemm's canal. Coming to GATT prerequisites. The surgeon's preparation begins by performing gonioscopy in clinic, identification of landmarks and adequate intraoperative gonioscopy practice prior starting any minimally invasive glaucoma procedures. Beginners should select patients with care, having good neck mobility, without head tremor, with good cooperation and visible angle in the clinic. Begin by tilting the microscope 30 degrees towards the surgeon and rotate the patient's head 30 to 35 degrees away from the surgeon. Patient should be in reverse Trendelenburg position, with head above the heart. This helps to prevent blood reflux from the Schlemm's canal. The surgical weapons for performing GATT includes 5-0 prolene suture, a low-temperature cautery, MVR blade, max grip forceps and a Swan-Jacobs lens. Now steps for performing combined phacoemulsification with GATT includes: first, a clear corneal incision phacoemulsification with implantation of foldable intraocular lens is done by the surgeon seated temporally. A 1 mm paracentesis oriented tangentially is made supranasal or infranasal quadrant depending on the laterality of eye. A 5-0 prolene is thermally blunted with a low-temperature cautery. A high-density viscoelastic is injected in AC to widen the angle. After adequate tilt of both patient and microscope, apply generous amount of viscoelastics over cornea before docking Swan-Jacobs lens. Then identify the anatomical angle structures. Goal is to achieve an in-face view which provides clear separation of angle structures. A goniotomy incision of 1 to 2 mm is given at the level of anterior trabecular meshwork with a MVR blade which exposes the posterior wall of Schlemm's canal. The suture is then gently threaded along the circumference of Schlemm's canal until the distal tip emerges from other side of incision, thereby completing 360-degree trabeculotomy. The viscoelastics are removed by irrigation and aspiration, and corneal wounds are hydrated to ensure watertight closure. At the end of the procedure, AC is filled with 25% of 1.4% sodium hyaluronate to prevent blood reflux from Schlemm's canal and occurrence of hyphema. Now, we shall begin with GATT performed in different and challenging case scenarios. A 65-year-old male patient diagnosed with primary open-angle glaucoma with IOP 32 mm of mercury and a cup disc ratio of 0.8 was on maximum medical therapy. After performing GATT phacoemulsification, IOP reduced to 14 mm of mercury and maintained to 16 mm of mercury up to 2 years without any AGM. A 57-year-old patient diagnosed with PCG had an IOP of 26 mm of mercury with 2 AGMs was taken for phacoemulsification with goniosynechialysis with GATT. An IOP maintained to 14 mm of mercury at 12 months without any medications. This patient had a history of trabeculectomy 4 years back and presented with pale avascular thick bleb and was on 3 AGMs. Post-GATT phacoemulsification, IOP reduced to 16 mm of mercury up to 1 year. GATT was performed in phakic patient, having uncontrolled glaucoma, resulted in IOP reduction to 12 mm of mercury without any AGMs. Now we will have a look of GATT and secondary glaucomas. 67-year-old patient presented with silicone oil-induced glaucoma, post-vitreoretinal surgery. After exposing the posterior wall of Schlemm's canal, 360-degree GATT was performed, which resulted IOP reduction to 17 mm of mercury, and was maintained till 9 months with eye drop timolol. This one-eyed neurofibromatosis patient presented with refractory glaucoma in right eye. Post-GATT phacoemulsification, IOP maintained to 14 mm of mercury without any AGM till 18 months. A 26-year-old patient presented with microspheraphakia, laser peripheral iridotomy was done. But still IOP was high, for which GATT phacoemulsification resulted IOP reduction to 14 mm of mercury, which maintained to 9 months without AGM. A 24-year-old female patient presented with typical features of Axenfeld-Rieger syndrome, polychoria, chorectopia, and with dental crowding, had high IOP on combination therapy. GATT resulted in IOP reduction of 19 mm of mercury, which maintained for 9 months with a timolol eye drop. There are minimal vision-threatening complications following GATT. Microhyphema is most commonly seen, which resolves within 2 weeks. Macrohyphema is defined as layer of blood greater than 1 mm in anterior chamber, which requires AC wash if non-resolving. Other complications includes blood clot, blood staining of posterior capsule. Rare complications such as iridodialysis and cyclodialysis cleft can also occur. GATT has been reported in various spectrum of glaucoma ranging from open-angle showing favorable long-term outcomes, also in secondary open-angle glaucoma following vitreoretinal surgeries and in patients with prior failed glaucoma surgery. Recently, it has also been explored in primary angle closure glaucoma with good promising outcomes. To conclude, GATT is most economic, safe, versatile, and an efficient procedure.